all of you, and hopefully some members of the public will join us as well. This is obviously the November meeting of the Council of Governors, a busy agenda, building on the Foundation Group 3 board meeting that we had last Wednesday, where we brought together SWIFT with the George Eliot and Wye Valley boards to compare and contrast performance across the Foundation Group. Things are obviously very tough at the moment in the NHS, but at SWIFT, relatively, although tough, we are continuing to outperform our peers, but that's not to say that there is not still significant room for improvement. In terms of apologies for absence, I'm aware of Sharon Ellswood and Paramjit Gill sending their apologies. Do you have any other apologies, Sarah?
We do. So we've also got Ruth Cowan, Kathy Wagstaff, Roger Weddell, Yasmin Becker, and Graham Nuttall is going to need to join and leave the meeting around a personal commitment.
Okay, great. Thank you very much, Sarah. So we'll duly note those. Any new declarations of qualification for office or declarations of interest? Please raise a digital hand if you need to say anything at this point. Okie dokie, I can't see any hands raised, so we'll keep the records as there being nothing new in that regard. The minutes of the meeting held on the 8th of September. If you weren't happy with the accuracy of those minutes, could you please raise a digital hand? Again, can't see any digital hands raised, so I'll take those as an accurate record of that meeting held on the 8th of September, and will duly sign the minutes. In terms of matters arising, we go to page 23 of our pack, and the first was regarding the Patient Safety Surveillance Committee update, and that was shared by governors on email on the 2nd of September, so thank you for doing that, Elaine. And then on the Ockenden report, Mary to Malloy to add the maternity priorities to the list of training issues for the governors. That was done, thank you. And then we have on the agenda for today a discussion on progress on Ockenden, so we will discuss that a bit later. On the international nursing front, myself and Glenn to consider options available for helping countries to train more nurses to help with international nurse recruitment. That's being addressed nationally, Glenn, by the NHS. But I did have an interesting meeting this morning with Jane Knight, one of our governors, on the One World Link work that goes on between Leamington Spa and Bow. And we are exploring ways that we can potentially develop relationships with that organisation to the betterment of both parties. In terms of actions in progress on the clinical governance assurance report, Glenn to report back to governors an update on radiology and pathway recovery. Glenn, are you going to pick that up in your update?
What we thought with that one is we'd give it a little bit further time to demonstrate the improvements, but I'll probably report on that next time, Chairman, if that's okay.
Okay, thank you, Glenn. And if there's anything substantive to report, obviously you'll do that in the monthly board meetings anyway. And then on the Levelling Up report, that's been added to the agenda, so we'll be talking about that a bit later. Thank you, Anne. And then on the Finance Assurance report, that was to ensure that the papers were circulated in a timely way. Thank you, Kim and Sarah. Then on the Patient Experience Group update report, the volunteer risk assessment form to be circulated by governors. I assume that happened, Sarah, but was Sharon doing that? It's not showing anything.
Yes, that's correct.
Okay, thank you very much. And then Glenn to see confirmation that the patient portal could be accessed through devices other than a smartphone. Glenn?
Yeah, and it can, and I think during the last meeting I posted a link to show how that can be done. You need a landline verification code, but otherwise you can access it through any computer device.
Okay, thank you very much, Glenn. And then on the Wayfinder project, RL, Roger Lloyd. To liaise with Ruth Cowan to confirm if Ruth Cowan can deputise in his absence. That was done. Thank you, Roger. And then the finance and performance meeting agendas be shared with the governors, and that was done. Thank you very much. We are looking at, Mary Malloy and I, with Simon Page and Richard Collier's Deputy Chair and Chair of the Audit Committee respectively, having a session after the finance and performance meetings with governors who are interested to see, to give feedback on, if you like, business oversight in the way that we used to. So we are looking at how we can make that happen. Are there any matters arising that I've missed? Please raise a digital hand. Okay, I'm going to have to jiggle the agenda around a little bit, so apologies for that. So we're going to start off first of all on the governance requested assurance on the Levelling Up report, but we then have the finance update with Kim Lee, because unfortunately Kim needs to send apologies after that. So Anne, I think we're over to you on the fantastic work on Levelling Up.
Oh, thank you very much, Chair, and thank you for an opportunity to attend today's meeting. So you have in your pack a covering note, and the report that we published in April attached as an appendix. And if I may draw out 3 points, I suppose the first is the context. The Health Foundation earlier this year published a report on inequalities that really flags, I suppose, why this work's important, and the stark differences in health outcomes across the UK, with a gap of almost 19 years in healthy life expectancy between the most and the least deprived areas in England. And it's really around inequalities in power, money, resource at local and national levels. You know, makes people's daily lives more challenging, and this in turn can make people more vulnerable to poor health. And really, to make inroads into this area requires partnerships and collaboration, and it is featured now. It was identified, it came into sharp focus as part of the COVID-19 pandemic, and we have had the Levelling Up white paper and the Levelling Up and Regeneration Bill in May 2022. So that's sort of the context and the rationale for us as an NHS trust. So the second point links to the Foundation Group objectives, and we worked with the Purpose Health Coalition, and detailed in the covering letter provides a little bit of background to the Purpose Health Coalition, who it brings together, you know, leaders, businesses, universities, NHS trusts, councils and charities from across the UK who are committed to breaking down those barriers as we recover from COVID-19. And there's a link very much to the Foundation Group objectives. Our work with the Purpose Health Coalition spans the Foundation Group, so George Eliot and Wye Valley are now working alongside. And actually, I found out yesterday that Warwickshire County Council are planning on engaging the Purpose Health Coalition. And what that partnership enables us to do is to really take stock and benchmark ourselves against the 14 goals. And those are listed, and some examples of good practice listed in our impact report, but areas where we have opportunity perhaps to do more as an employer, as a provider of health and care services, and as a partner within the integrated health and care partnership. And also, really importantly, starting to think through the metrics, evaluation of impact. So by doing and by working in this way, what impact are we having on the populations served? And that's one of the products that we've got. So we've got, that's the third point I wanted to draw out, the product that we have a benchmarking report as part of the impact report, which is in Appendix A. We've also contributed to a document, Leadership of Tackling Health Inequalities, that was published in July 2022. That report is available and publicly available on Purpose Coalition website. And that sets out some good examples across all other trusts that are participating and working with the Purpose Health Coalition. I was flicking through some of them earlier as I was preparing for today. And the areas that we flagged were around pulmonary, around physiotherapy and pulmonary rehabilitation, and starting to think through where are we providing services, pulmonary rehabilitation services for our population. And the work that Adam Parchment with Michelle Greening did identified areas of need and therefore looked at location. And that's the level of detail and understanding of our population health and the stratification and that we need to understand to work to improve health outcomes for all and start to make inroads into that stark gap that exists in healthy life, in healthy life expectancy between our most and our least deprived areas. We very often think of South Warwickshire as being you know, well resourced, but it is not without its areas of deprivation, and it's our responsibility in our work as an anchor organisation, as our work as a partner within integrated care partnerships and integrated care board, to understand those and to look to improve access and to improve outcomes for all of our population. And we gave an example that was shared in an elective case study for NHS Midlands, where we've done some work on the development of a risk stratification score. And what that's resulted in is a reduction in patients living in our most deprived areas appearing on the waiting list. And that has coincided with the reduction of our longest waiters. And we're doing further work on prioritising patients with a flag for learning disabilities and addressing the health inequalities faced by cancer patients. So that's the context that we're operating, the need for this work, the products, what we have done to date and how it fits with the foundation group objectives and I suppose the requirements that are set out on us as an NHS organisation within the Health and Care Act. Thank you very much. Happy to take any questions.
Thank you very much, Anne. Questions and perspectives to Anne. John?
All the economic work that I've looked at has put South Warwickshire into the wealthy southeast. Coventry and Nuneaton, however, are all in the deprived north. Have we compared, for example, Nuneaton with South Warwickshire and tried to understand what are the reasons for any deprivation or problem? But right now, I would have thought South Warwickshire was in the leveled up.
Anne?
Yes, it is certainly better on than the areas that you've identified, but it has its own challenges. Rurality, it has its own challenges in some of our neighbourhoods that are identified through the stratification that has been done. So there's a lot of work on super output areas and understanding that the district councils are doing. So it's, in terms of understanding reasons and rationale, it's complex, isn't it? It's some of the economic, educational, long-standing issues. It's understanding what we can do ourselves, what we can do, and what other areas and what other opportunities there are available through our partnerships. But we do have those areas. We do have areas of deprivation, and our work with Citizens Advice actually identified that in an area where it's perceived as being levelled up, if you are coming from a deprived background, the gap seems even greater. So it does exist for us, albeit not in. It's a range, isn't it? It's not completely levelled up.
Yeah, I think that it is. It's quite stunning, to be honest, the difference between life expectancy in Stratford-upon-Avon compared to, say, Bedworth, which is obviously just outside our zone. I mean, I think it's almost 15 years as a difference in life expectancy, which is incredible. But for me, part of the levelling up agenda is also enlightened self-interest. The longer we can help people live longer, happier, healthier, independent lives, the cheaper it is for the country, to be honest. Glenn, and then I will go to Mike Wells, and I'm conscious Mike Flaxman has put a comment into.
Yes, I am. Yeah.
Okay, can you just bear with me a second? I'm just going to.
Yes, we have. Yes, we've got a box you can have, Edith. Definitely.
Okay. So thank you, Russell. I was just going to respond
Yes,
to.
of course you can.
Glenn, you'll need to go back on. I've taken everyone. I've muted everyone. If you can now come off mute because we couldn't hear you. So,
Okay. Yeah, thank you, Russell. I was just going to respond to John's point now, in the same way that Anne did, really, which is the funding that comes to each part of the NHS is already based on a deprivation and a age stratified formula. So and I think a lot of concentration on levelling up seems to be about how much money goes from one part of the country to the other, and to an extent, that's taken account of with the formula that we work within. But the challenge for us, I think, is with the resources that we have for South Warwickshire, is how we then level up within that allocation that's already taken account of. And as Anne said, there's parts of South Warwickshire that are deprived. There's communities that are deprived, and it's how we ensure that within our patch we level up and that we tackle those inequalities with the services that we design and the interventions that we put in place. So it's very much primary care network based levelling up would be the way that I'd rather look at it.
okay, thank you, Glenn. Mike?
Thanks, Russell. It was just to confirm that even down here in Shipston, there are definitely people who are in food and fuel poverty. So the levelling up agenda cuts right across the whole county. It's just numerically it might be small here, but to those people it really matters.
Yeah, no, absolutely, Mike, and Mary Malloy makes the same point. Just before I move on to Joe, Mike Flaxman has asked a question, Anne, about how widely circulated the impact report has been, and questioning whether it's available on the web. He wasn't able to find it.
Yeah, it is. Sorry.
Okay, can you maybe try and post the link into the chat box? That would be helpful.
Yeah.
And Joe?
I will reiterate what Mike said about super output areas, not lower super output areas not being something that we see in this neck of the woods. But if you then go down to lower levels than that, and families, which is something that we're feeding through in the community's quadrant place development plan, which probably means very little to most of you, but I seem to spend my life on this kind of thing. And that feeds very much into the levelling up agenda as well, but looking at it at a different scale, because of course South Warwickshire itself doesn't feature in the same way as Nuneaton and Bedworth.
Yeah, no, thank you, Joe.
And I run a food bank, of course.
And apologies, I should have made it clear. Obviously, our trust covers Nuneaton, Bedworth, with our community services and family health and lifestyle services into Coventry. So this isn't just a South Warwickshire issue. So we are broader in our footprint than South Warwickshire. So, and you will notice some of the case studies there talks about Coventry and so on. So my apologies, I should have also made that clear.
Thank you, Anne. And Callie?
Yes, thank you. I know there's loads of stakeholders involved. All the stakeholders were involved in setting local goals and all that sort of thing. And how do you come together? You have regular meetings, because obviously you mentioned something about local leadership. Is there a group of people from different stakeholders, and how do you work? Because obviously you have to agree goals and then you're going ahead with measurements. You mentioned that you have targets and measures in order to measure progress. And I just wonder how it all been decided. That's all.
Yeah, that is a good question. So it's the leadership of this is through a number of routes, but it is settling. And so I mentioned yesterday we met as a South Warwickshire levelling up group, which included the police, Warwickshire County Council, the districts and ourselves as a sort of an oversight group. And so that is going to use the Purpose Coalition to look across all of our organisations. So that's establishing itself, but this is our report, so we already have a sense of where we work well and work that we need to do. So it cuts across, and different organisations, as you might expect, are at different stages in their work internally, but also in developing those partnerships. So it's getting established through levelling up groups that have been developed across all 5 districts, and they've been convened by Warwickshire County Council to progress this against the Warwickshire County Council overarching work plan on levelling up.
Thank you. I just want to tell the chair that I cannot fit into the chat. Sorry, I cannot fit into the meeting chat personally. I don't know, other people can, but I cannot. That's all I'm saying. All right, it doesn't allow me. Thank you.
No worries, Callie. Just raise a digital hand if you want to make a point there. Thank you.
Okay.
And any other questions or perspectives? This is really great work, Anne, which has got national recognition, and under your leadership, Swift is really taking a lead role. So thank you for your hard work, and it's incredibly important for our citizens. But as I said, there's also an element of self-interest from us, helping all of our citizens to have longer, happier, healthier lives. Thank you. We'll move on then to the finance update to free up Kim. So Kim, we're over to you.
Thank you very much, Chair. Feedback there. So this is the month 6 report, and we're reporting a break-even position compared to an expected plan of 1.5 million surplus. In terms of the forecast, we've just received some further guidance from NHS England around the fact that any changes to our forecast requires a formal board approval as well as NHS England approval. So we're just trying to work through what that means for us as an organisation, and we will be having more further discussions around our forecast position at our December board meeting. The agency spend remains higher than the ceiling, but our spend in month seems to indicate an improved trajectory. So fingers crossed that the we've been doing a lot of actions recently around reconfirming our agency controls and ensuring that that message is cascaded throughout the organisation, and hopefully we're seeing some sort of green shoots really in terms of a reduction in spend. The capturing and reporting of our cost improvement programme is part of the focus of the financial reset and recovery programme work, where I gave an outline to the Council of Governors members at the recent round table, and that piece of work is progressing well. The key focus is around controls and compliance, but also around how we support the divisions in terms of delivery of their financial position for this year, as well as supporting them on identifying opportunities for recurrent efficiencies. The other update I want to give is on capital. You will note that we are behind in terms of spend against our capital programme. However, we are proceeding at risk at the moment in terms of ensuring that we are moving forward on our elective hub. We're still waiting for formal confirmation that we can proceed, but we've had a lot of positive indications, so that's good news. But I think that's all I wanted to say at the moment, so happy to take questions.
Thank you very much, Kim. Questions and perspectives to Kim. Roger?
Yes, Kim. In the statement of comprehensive income shows the deficit of 1.497 million, but you say we're reporting a break-even position. That doesn't sound like the same set of figures to me.
So the key thing is to look at the actuals, Roger. So I report on the actual position. So that's the actual income over expenditure, where we're saying it's, I said, well, breaking, it says £7 or £7,000. So it's broadly break even effectively. I think it's some roundings there. So it's the third column in on the statement of comprehensive income. The final column, the final column is the variance. Again, just rounding up, it's £1.5 million variance compared to where we need to be, or where we plan to be, should I say.
Right, thank you.
Okay, thank you.
And thank you, Kim. Any other questions or perspectives to Kim? So Kim, this is clearly proving to be a very, very difficult year, both with us coping with the block contract arrangements as well as excessive spend on agency costs. Is it still your view, best view at the moment, that we will break even this year?
At this point in time, yes. I think we do need to have the further conversation, obviously, at board around what we deliver. I know that the you know, as an organisation, we're always keen to ensure that we deliver a surplus, but that it warrants further discussion at board in terms of how we land this year, because it has an impact really on where we head into the new year and start the new year. So I think those are the conversations that we need to have.
Okay, thank you, Kim. Roger, your hand's gone back up.
Yes, a second question was on the cash balance for the group, 35 million. The group I'm taking to be Swift and Swift Clinical Services. Innovate, I presume, is outside of this because it hasn't had a complete financial year. Am I correct on that?
Not quite. So the group is the trust and Swift Clinical Services. The Innovate Services is a separate organisation, and their figures are not consolidated into our position. So it's not related to them being having only been in operation for part of a financial year.
Okay. Thank you.
And Mike Flaxman, and then we'll move on.
Yeah, I just remain concerned about the delivery of the cost improvement programme at the moment. It's not looking good on the presentation we've had today, as far as I can see. And schemes still haven't gone through quality impact assessment to see whether cost improvements have an effect on the quality of services. So I'm quite concerned about whether we're going to deliver our cost improvement target.
Okay, Mike, my first comment before I move to Glenn would be I don't want governors being concerned. It's for the board of directors to be concerned rather than governors. But Glenn, what would your observations be on what Mike said?
I mean, so the cost improvement programme has deliberately got the word productivity in it, so cost and productivity improvement. And what we try to ensure is that we take a productivity and improvement focus on it. So I am confident that all of the schemes that get approved do not have a negative impact on the quality of the organisation. In fact, many have a positive, because they're introducing innovation and productivity gains that benefit patients. Obviously, we're in a really tricky year, and I don't think if you were a council of governors for any other acute provider, you'd be looking at a surplus plan. So I'm very aware of the challenges we face and some of the uncertainty around the way that inflation may impact on the NHS in the final quarter of the year. So it's a challenging time. I think we've always sought to find cost and productivity improvements that are recurrent. It's harder these days to find recurrent opportunities, but the team are working hard to do that. So I'm with Kim that I think we can certainly meet our statutory duties of being break even or better, and there's a challenge about how much above break even we can achieve.
Okay, thank you, Glenn. But my jokey aside, Mike, is a serious one. I really don't want governors being concerned about the financial performance of the trust. That's for the board of directors to be worried about.
Sorry, that does concern me a little bit, Russell. Perhaps it's my confusion about the role of governors.
Yeah, well, hence my sort of clarification. I mean, it's for the board of directors to deliver the performance. It's not for governors to deliver the performance. It's for governors to hold the NEDs to account if the performance isn't being delivered, and to be the voice of their public constituencies or stakeholder constituencies. So, there's quite clearly a difference between the role of non-executive directors and governors in that regard. Okay, team, any other questions or perspectives to Kim? Okay, thank you very much, Kim. We'll allow you to escape, so to speak. Have a good rest of your day. So, Glenn, I think it's back now with you on maintaining patient flow safely during the winter, which was the next governor requested assurance item. So, Glenn, over to you.
Thank you, Russell. As you say, there was a request from governors to provide assurance on this, and what I've done is included within the paper. Apologies, there was a slight amendment to that late on. A document that went to the September public board meeting, which is entitled "Planning for Winter," which is a presentation that Harkamel, our Chief Operating Officer, presented to the board, and she did it extremely well. So what I would suggest to governors before you listen to my version of it is that if you've got a few moments, go online and have a look at the recording of that meeting, because Harkamel took the board through it, and it's a good paper. And what that paper does is it sets out the challenge that we face, looks at the profile of demand that we've experienced over the last period, and projects that forward into this winter. It also brings into it some modelling based on some scenarios, including, as you can see, we've had to take account of the likely impact of flu, and based on some of the experiences that they've had in Australia, there is no doubt that this winter we are already seeing more respiratory illness, which is a result of a couple of winters of lockdown, which have suppressed some of that. So in addition to already being busy, we have additional respiratory illness. We have a rather uncertain COVID scenario for this winter, but we need to be prepared for other waves. And then we've got a number of staffing challenges, including still the prospect of industrial action in other groups other than the RCN. So we will prepare ourselves for that. I suppose the other thing that the data shows us as well is that because we've been pretty good at managing urgent care, we've also seen a degree of increase in activity coming through intelligent conveyancing of ambulances. So ambulances from sites on the borders of Warwickshire have been coming to Warwickshire because they can offload their patients more rapidly and get on to the next patient. And whilst that's a great thing for the NHS, it's certainly added to our demand. And I spent an hour with the A&E consultants yesterday talking to them about that and the impact that it's had on them and how we try and plan our way through it. So in the context of all of that, we come up with a 73-bed challenge. I'll firstly caveat that with it's 73 beds or bed equivalents is what we look for. And actually, the best solution to this is not to just add more beds into the hospital, even if we could. The best solution would be and is to put in different care models that are better for patients, that avoid those beds. So when we say 73 beds, it's 73 beds or bed equivalents. And there's a really good chart on slide 12 of the pack that shows with that circle a number of winter planning schemes that were in place at this point, actually, which is this came to our September board. There's been a few additions to that since, which is good. Looking at pre-hospital and admission avoidance, looking at streaming within the emergency department itself, looking at some of the in-hospital flow opportunities, and then some of the opportunities to discharge patients more rapidly. And all of those come together to deliver a set of schemes that at the point of that being reported through to board, we had 57 beds and or bed equivalents. So we had a bit of a gap to find, but I'm pleased to say that some more work has closed that gap, and we'll give an update on that in the next board meeting. So so what we're saying here is that with these schemes in place, we can address some of that increasing demand. You can see from the chart that generally the period that we find ourselves under more pressure is in around mid-January time. Generally the pre-Christmas period looks a little bit better. It always interests me when I come into hospital on Christmas Day that we have lots of empty beds. There's something there about the support that families give, and it's a shame that isn't always there throughout other parts of the year, but we won't go into that at this point. So those schemes are there in place, and we will continue to monitor it. We've got really good escalation processes in place. We will go into Silver and Gold Command as a system. We've gone into Gold Command mode. So Coventry and Warwickshire, there's a meeting every Thursday afternoon where we take stock of how we're doing as a system. These schemes are all on track to deliver the bed impact that we've identified. I suppose in addition to all of this, we will encourage people to innovate. So within the pack, you can see the 100-day discharge challenge is there, and that was based on the work of the National Discharge Task Force on 10 best practice interventions. We've looked at those, we've helped to shape some of those. You can see we've done some things already that have helped us to improve our performance. The other thing, though, that we will be mindful of throughout this winter is the need to support our workforce to create resilience amongst our teams and to support our teams. And that indeed was part of the conversation I was having with the A&E consultants yesterday, and the role that they play as leaders in their department to support those around them, but also to support themselves. So I think we've got a good plan, but and you will have heard me say this before, but it's true, this will be the toughest winter that we've faced as an NHS. I think we're better placed than your average trust to cope with it. That's all I was going to go through, Russell.
No, that's great, Glenn, and it's great to see the sort of level of logic and maths applied to the problem. But as you say, we are very, very aware as a board that it's the phenomenal efforts of the frontline teams that make all of this work, and the agility and a willingness to adapt ways of doing things, which is important. Just before I open it up to general questions or perspectives, and there are some points in the chat box, Glenn, if you can just have a look. But there's lots of talk in the press about medically fit for discharge being a real challenge at the moment. How assured are you that in terms of the way we address medically fit for discharge challenges, that it won't be a significant problem for us during the winter months?
So at any one point, we've probably got about 60 patients across the hospital who are deemed fit for discharge and are therefore in the wrong place. We work really closely with Warwickshire County Council and other partners, including our community services, to keep that to a minimum. I think we're really on top of our numbers. They're validated through our bed meetings that take place throughout the day. And any of you who saw the piece on BBC National News will have seen some of those processes in action. So we're really on top of it. And I think all of the work that I've been involved in with the National Discharge Task Force tells you that if you know your numbers, then you can generally start to address them. We are looking at being one of these integration pilot sites for looking at improving domiciliary care, and we've got some actions that we can implement this winter with support from the national team, and we'll be doing that. But if we had a fully recruited team, NHS and care system, I'd be having a very different conversation with you. And so we have to be really conscious of the fact that it is gaps in the workforce that are causing many of these delays. And you know, those numbers I've just quoted, that 3 wards worth of patients that firstly could be freed up for other activity, but secondly, that actually the longer patients who shouldn't be in an acute hospital stay in an acute hospital, the more they decompensate, and the more actually many of them need more expensive long-term care packages. So there's an absolute imperative financially, operationally, from a safety perspective to minimise that. So and that's our focus. And I certainly wouldn't want to be critical of any partner organisation because they face similar workforce challenges to us. But we know our numbers, we agree on numbers with local authority colleagues. We've got Becky Hale now, who's an executive director in our team, but also in the local authority. So we're very close on it, and we'll manage well this winter as a consequence. But I suppose the other bit to say on that point in a public meeting is there's a lot the public can do to help us, including supporting friends and relatives, both to prevent admission, but also to help us to get people home.
Thank you, Glenn. And any questions or perspectives to Glenn? What does G&A mean, Glenn, on bed-based?
Yeah, apologies, Roger. We love our jargon. So G&A is general and acute. It's referring to general and acute beds, i.e. it excludes the paediatric beds in our system. So apologies for that one creeping in there.
Thank you. I've worked through many of the acronyms, but that one defeated.
Sorry, does that include maternity bed? Sorry, labour.
No, it doesn't.
It doesn't. Thank you. Okay.
And any other questions or perspectives to Glenn? So you'll keep us briefed on a monthly basis anyway, Glenn, as we enter the challenging winds and weather of winter. So just for members of the public, the way you can help us help you during winter is if you're offered a flu jab, please take it. If you're offered a COVID jab, please take it. If the weather's very icy outside, really consider whether you need to walk, because falling over in the ice is a really challenging situation for you as an individual, as well as us looking after you. So I think there is a degree of help you can give us to help you. We'll move on then to the operational assurance and the quarterly status update report, the red, amber and green report. Glenn, over to you.
Thank you very much. This is the second time you've seen this year. Obviously, we bring this on a quarterly basis and it assesses our progress against the annual trust objectives, which we agreed in partnership with governors and other stakeholders, including our staff. So I won't go through it all because it's all there for you to go through. I just wanted to highlight one or two things that maybe need a bit of attention. So generally the things that aren't green. On the sustainability section, you'll see there's a couple of bids for resources that have gone in. One is for funding to decarbonise the Warwick site, which is an 8.1 million bid for what's called SALEX funding, which is national fund available to invest in carbon reduction schemes. We have to contribute locally 11% towards that, but otherwise that's money that we can get from outside the organisation, which is really helpful on that agenda. We await the outcome of that bid, but we hope that will be successful. We have also been, we've also put in a bid for the elective care hub. Now, as part of our state strategy, which you've previously seen, really important for us to replace our day surgery theatres. And we put in a bid earlier on in the year for some of this national transformation funding. We were a reserve bid, a first reserve bid, and there's been slippage elsewhere. So we were asked at quite short notice to bid for, at that point it was below 15 million, but they've increased it a little bit. So you can see there we've put in a bid for 16.9 million pounds worth of capital which would allow us to progress at the first phase of that really important project. So again, we're waiting. We have to spend that money within this financial year. We put in a bid within a week of being asked for one, and several weeks later we're waiting for confirmation about whether that will or will not be supported. I keep pointing out to regional colleagues we're running out of time to be able to spend it. So I hope that we will get an answer on that one soon. I was then going to turn to the reference to patient-initiated follow-ups. There's a requirement nationally to increase the number of patient-initiated follow-up outpatient appointments. It's quite hard for us to do because we already have a low new to follow-up ratio. So for us, for every one new patient, we have about 1.9 follow-ups. Some trusts have about 4 follow-ups to every new. So reducing that is a little bit more challenging for us. Personally, I would rather not put patients into patient-initiated follow-ups. If they don't need follow-up, I'd rather refer them back home and give them the positivity of saying that your acute episode is over. So we are modernising and reducing outpatient follow-ups. Elsewhere in the report, we give an update on some of the things that are going on at Place, and you heard already from Anne about some of the great work we're doing on levelling up. We are also working with the national team on that integration frontrunner integrated care pilot that I described earlier. There hasn't been a national announcement on these pilot sites yet. You may have noticed we've had more than one Secretary of State over the last few weeks. I do hope that the new Secretary of State is able to announce that soon, but regardless of a national announcement, we're still getting on with that project. We're also trying to ensure that we progress the lead provider model. And again, I think we're well placed to progress that here because of some of those joined up posts like Becky Hale I referred to earlier that give us that capability to take on some of those commissioning responsibilities. But to do so, we'll probably need to go a little bit faster than the Coventry part of the ICS. And what I'm trying to ensure in the integrated care system is that we're not kind of lowest common denominator approach to this, that if Warwickshire can go faster, then Warwickshire is allowed to go faster. So we will ensure that we do that. There's a bit of a red there on developing a financial framework. That's a bit stuck at ICB level, but I see some signs of that moving forward. And otherwise, Russell, I wasn't going to go through lots of other detail, but I'm happy to take any questions or answer any questions via email if they're more detailed.
No, that's great. Thank you very much, Glenn. Any questions or perspectives to Glenn on the operational assurance report? Callie?
Oops. Yeah. Thanks, Russell. On page, I don't know if you have the same page numbers, but anyway, it's number 9. Implement the national strategy of operating a place. I know Anne Coyle is leading on that. I just wanted to understand the integrated care board. It's part of the place structures, because all I wanted to understand is a bit more about what the role of the care collaborative is, and what constitutes level 2, because it says in that current focus on moving to level 2. It says that that's the aim, to move for the care collaborative to move to level 2. What is the role of the care collaborative and what that means, moving to level 2? That's my question.
Yeah, and it's good, and it's a good question. I could give you a very long answer, but the quick answer of that one is the approach that has been adopted is that you can gradually devolve responsibility down to lead providers. The level 2 is to do that through a subcommittee of the Integrated Care Board first, before you then move to level 3, which is to push that down to the lead provider and sole kind of responsibility. My preference is to move as quickly to level 3 as we possibly can. And there's a bit of a discussion going on with the ICB about whether we have to move through this in a kind of annual process of assurance, or whether we can go more rapidly and we can demonstrate that we're ready for it. So Callie, I'm happy to give you more on that later, but that's the simple version of something that's got probably a bit more complicated than it needs to be.
Okay, but the role of the care collaborative is to achieve goals across place, or is what that's all?
Yeah, so the care collaborative would be led by South Warwickshire Foundation Trust, would cover the whole of Warwickshire. So within that, we would need to ensure that we have suitable arrangements for the Warwickshire North place, for the Rugby place and the South Warwickshire place. But we would be the overarching lead provider for that care collaborative, and it would involve all the partners in the delivery of those services.
Thank you.
I think for me, the key point, Callie, is the one Glenn was making, which is this is all very complicated, and Anne does a remarkable job steering us through it. But the key thing for our citizens is that we start to make stuff happen to the benefit of health outcomes for them and at lower cost of delivery for taxpayers. So the issue is one now, I think, of pace rather than governance arrangements. Any other questions to Glenn on the operational assurance report? Okay, I think I would just observe that I think the executive team are doing a remarkable job in the context of all of the problems that we are facing as a system as we are halfway through the year. So we're then on to the patient experience assurance report. Sarah, lovely to see you this morning. Thanks for all your hard work. You've done a great job since arriving to sort of step into Fiona's shoes. So thank you. I know you're having a real impact. So what would you like to pull out of the patient experience assurance report, please, Sarah?
Thank you, Chairman, and thank you for the opportunity to describe this quarterly patient experience report. So the report gives an overview of our patient experience metrics, and then it also describes some of the great innovations and improvements that teams across the organisation are taking forward to help give our patients the best experience. So if I may, I'm just going to pull out a few points because I could probably talk patient experience for the whole afternoon. So in terms of our metrics, Swift continues to benchmark very well, very positively against the traditional patient experience metrics, if you like, that all acute and community organisations measure. So we continue to have a low number of formal complaints. And the report highlights there's no one particular area which has a large number of complaints, which is really good news. And we continue to have overarching, very strong family and friends, so that I want great care feedback in terms of that opportunity that we give to every patient in our care to tell us about their patient experience. It's also really good to see our PALS team, so that's our patient advocacy liaison team. So that's the team that deal with informal concerns that patients across the organisation may have. They're doing some really proactive work to make it as easy as possible for patients and carers to contact them if they've got a concern, so that we can try and deal with any concerns at the earliest opportunity and solve any problems that patients and carers may have. They produced an easy read PALS leaflet just to make it a little bit easier. And the other thing they've done, which I think is quite innovative, is they have piloted and now got permanently in their team an assistant support worker to focus on living with disability and autism. The report details some of the advice that member of the team has given to our outpatients department to help them make it easier for patients who may have a disability to signal that they need a bit of extra support. And I think that's a really innovative, really good development to see. There's other improvements described in the report, and I was just going to pull out the fact that it's good news that over the summer we were able to reintroduce the bereavement listening service and the bereavement cafe. It's such an important service for patients. Really good to see that reinstated following having to cease it during the pandemic, and also good to see that the end of life team, again, they take forward numerous developments, but I think the availability of ICE lollies and seeing that sustained is really good. And I'd just like to close by just saying a little bit about our ward accreditation programme. So this is a programme that we've had in place at Swift long before my time, but for the last 12 months. And we've now done a cycle of I think all of our inpatient wards. And it's a national tool that we've adopted, but it's an improvement tool which helps individual wards look at from a quality of care, from a nursing perspective, the things that they're doing really well, and it gives them an areas of focus for things that they might like to focus on improving, and maybe give teams a bit of support with doing that. Patient experience is a really key part of the assessments. It runs as a golden thread all the way through the accreditation process, and it's just really lovely to be able to say that during this quarterly report there were 2 wards assessed, Chadwick and Charlecote ward, and they both were assessed as outstanding. That's really difficult to get, and so that's good news for our patients at Swift. So I'm really happy to take any questions or comments that people may have.
No, really good work, and the ward accreditation work is really encouraging as well. Thank you, Sarah. Questions and perspectives, Mary?
Yes, it's just a clarification of the data. The complaints data, we've got March to May 2022. It seems quite a long way out of date. Is there a reason why we've got nothing later than May 2022?
Glenn may have to help me with this. The report that we've given, as I understand it, is the most recent quarterly report that's been through the board of directors, and that I think is traditionally the quarter that they report on at the last time it went through the board of directors. So Glenn, I don't know whether there's anything else you need to say on that.
Yeah, that's correct. I mean, obviously more up-to-date information will probably be in our December board pack, I would have thought, Sarah. If
it
is.
I've just looked at the report. Yeah.
No, thank you, Glenn. Thank you, Sarah. Thank you, Mary. Callie?
Yes. Hi, Sarah. I just yeah. I know you said that the ward accreditation tool is a national tool. Just if you, I don't know if there is information accessible that we can look into that tool, or it's only available for healthcare workers. And the thing I wanted to ask is that all the wards are being assessed, and are they accredited like on a monthly basis? Is there a rating system? That's all I'm asking. Obviously, there are criteria for this accreditation, and maybe. And is it the same criteria that apply to all wards? That sort of thing I'm asking, because different wards have, you have surgical wards, you have all sorts of wards anyway. So that's all I'm asking. Sorry.
It's a really, really good question. So I'll have a go at it. The accreditation tool is not something that is mandated nationally. It's something that some organisations choose to use. And usually the organisations will take the framework and bespoke it, so develop the metrics locally that work for the relevant organisation, because it's used across many different organisations in the NHS. The key thing to say about ward accreditation is that it's not a performance tool, so it's not about measuring operational performance. It's an improvement tool. So within it, we look at the domains. So the nurse sensitive indicators, the outcome metrics that we measure on the ward, so things like falls, pressure ulcers, medication safety, We look at what the patient experience data is telling us and what our staff are telling us. And there is a visual, there's an inspection on the day, time spent in the clinical area, seeing how it feels, how it looks. And the key thing about ward accreditation is that you triangulate all of that data and discuss that data with the ward manager and wider parts of the team to talk through the things that are going well and the things that they might want to focus on improving. So we have Ellie Ward, the Deputy Chief Nurse, leads the programme, and there is a very, very detailed SOP that the senior team follow, because it's really important that we treat all of our wards fairly and using the same assessment tool, if you like. So we do have, on all visits, we have a member of the public or a patient rep. So what I would say is that if anybody's interested in joining any of the ward accreditation visits, then you would be more than welcome. Because what we try to do is view the ward through lots of different lenses and triangulate all the information that we get.
That's great. Thank you, Callie.
Thanks.
Volunteer if you like. Any colleagues can volunteer as well. Sarah, thank you very much. Just to be conscious of the time, team. Thank you, Sarah. We'll therefore move on to the clinical governance assurance report. Our clinical governance committee is chaired by Dr. David Spraggart, and unfortunately he's working today in his GP practice. So I'll take the report as read. Are there any, I know Jean and Mary, Mary, you're involved in the clinical governance work. Are there any questions or perspectives from governors on the clinical governance assurance report which is attached? I assume Callie's hand is a legacy hand. Callie, is that a legacy hand? Thank you. Okay, so are colleagues happy to move on then? Okay, super, thank you. And just for members of the public, governors often attend our monthly board meetings where there's always the opportunity to ask any of the NEDs any questions on behalf of members of the public, and David is obviously always at that meeting. Mary, your hand's gone up.
Yes, can I also add for members of the public that the governors have subcommittees of the Council of Governors that look at these assurance reports around patient safety, patient experience and governance, where they look at these in a lot more detail and ask questions which may not be asked here.
Super, thank you. And so we'll move on then to the audit assurance report. Richard. You're on mute, Richard. Still on mute.
It's fine, sorry. They've updated my team, so it's a different way of unmuting. This is the report for last year, so it's actually in Rosemary's name, and I would take it as read unless anybody's got any specific questions for me.
Okay, thank you, Richard. Rosemary, as it is in your name, albeit Richard's on the agenda, anything you'd like to add? No, I'm seeing
nothing else. No, nothing to add. No.
Okay, super. Thank you, Rosemary. So, questions or perspectives, Roger?
Yes, one question, and I think this will be for Rosemary rather than Richard. Losses and compensation report accepted by the committee, but what is the trend here? Are these going down? Are they hovering, or are they going up?
Losses and compensations are usually quite small amounts, so therefore things like when people lose their glasses or their dentures or something like that in hospital, and it's deemed that the trust was at fault and have to compensate for such things. So they're usually quite small amounts. I can't remember back to to the September meeting as to the values, but they've never been sums that we've been particularly concerned about.
Thank you. I thought this might refer to litigation losses and compensation, but if it's only the glasses, the hearing aids and things like that, then yes, fine.
Yeah, you could be right actually that in September there was a litigation which we hadn't seen before, which was then going to be picked up by the insurers, where we had to pay out first. But that's the first time. That was a one-off. But it's not the big. It's not the clinical claims.
Thank you. I was misreading it. Thank you.
Thank you, Roger. And Jane.
Thank you. Yes. I've just been looking at the report from David Spraggett, and it mentions that under number 2, that there was an update on the urology backlog and the haematology backlog. And as you know, I've been quite interested in both these departments, but I haven't seen that report and I don't know what it contains. So is there any way I can find that information?
I'll make sure through Sarah Collette that we get that appropriately to you, James. So we'll take that offline.
Thank you very much.
Going back to the audit assurance report, Callie?
I know later on the agenda there is an annual report from the audit group, and I wasn't sure where to ask about it, but that's where I saw that. Then my question was to do with this report, but it has to do with the pathology network, because there is something like the histopathology staff are directly employed by the trust, so that's why services have improved, but they're part of the pathology network. I don't fully understand how how the network works really, because I thought that they're not employed by the trust. That's all. That's my question.
So it's about the pathology network and who employs people in the pathology.
People that the work, yeah, that do the reports, yeah. And
Glenn?
So when the pathology network was created a few years ago, the view was that we needed to choupy all of the staff in the system over to UHCW for them to run that service. I think a number of us didn't feel that was absolutely necessary at the time, but that's what happened. It then became apparent that that wasn't working well, particularly with histopathology, because they were based on the Warwick site still, but were part of the network. So based on their wishes, I asked for them to be tupied back to Swift, and that happened. And since we did that, we've been able to increase the productivity of that team. But I think it's really important with all of pathology across the NHS that they're part of network arrangements, so that they're part of something bigger. But I think we've proven that they don't necessarily all need to be employed by a single employer. They can work in a network, but be locally employed and better managed as a consequence.
Thank you, Glenn.
So this they do work not only for trust patients, they do work for patients from other trusts. Yeah.
Correct.
Okay. Thank you.
Just sticking to the assurance report, Richard, is there anything you wanted to add?
Yeah, just coming back on Roger, the losses and compensations in September did include 464,000 for a tribunal payment which was approved by the Treasury and NHS England of £464,000. It's to do with a patient who fell out of a bed. So that was approved and that went off to the insurers. So it was to do with a patient.
Okay, thank you, Richard. And any other questions on the audit assurance report? Okay, team. As it's being a recorded meeting, if you need to take a comfort break, and I suggest you just sort of go off screen and have a comfort break and come back. The rest of us will continue. Now, Richard, if you could put your digital hand down, that would be helpful. Thank you. So we'll now move on then to reports from representatives on projects and groups. And the first is the Ellen Badger Hospital Site Redevelopment Update Report. Mike Wells.
Thank you, Russell. So I issued a paper that I wrote a few weeks ago, which I'll take as read. We had a project board yesterday, and the most interesting things to come out of it were, got 3 new members of the project board, got Neil McElduff, who's representing the ICB. David Spraggett has joined, so they make sure there's a NED representative, and Jo Barker has joined with her collection of hats that she brings with her. In terms of the demolition, which I reported has started, somewhere between 1/3 and 1/2 the building's now gone. You can see right through across the site. So definitely progress is being made. And last week on Thursday, Sophie and some of the team came to a Stour Health and Wellbeing Partnership meeting where it was agreed that we would work with them to co-design the Health and Wellbeing Hub. It was agreed that the low mass sort of cafe area still has a clinical look about it, and they want to get away from that so that it actually has a more welcoming feel. It's not just all sort of flat white walls and stuff like that. I think that also helps with it being more dementia friendly as well. Other than that, questions, please.
Okay, thank you very much, Mike. I do note that the League of Friends have organised the League of Friends of Ellen Badger have organised a march for next week in Shipston. Any questions or perspectives to Mike? Okay, thank you very much, Mike, and thank you for everyone else who's involved in that project. We'll move on then to the End of Life Committee update verbal report. Michael Coker. Michael, if you're talking, we can't hear you. Okay, I assume it's not me, so we'll move on. Actually, I think Michael has left the meeting at the moment. I can't see Michael actually being in the meeting, so we'll maybe return to that if Michael returns. David, on the Falls Group update, I don't think there's been a Falls Group meeting, has there?
Yes, 2 days ago, so hence the verbal report. The falls in September improved considerably, but we've just got the October figures and they are considerably up. The main reason for this is there's been a lot of I'm reading here, complex confused patients, mainly in Mayland and Victoria ward, which have increased the figures out of all proportion. The group are very good at following up problems. They will go promptly to find out what has happened, whether training is needed, advice or whatever, although part of the problem, of course, is shortage of staff at certain times. That's the main report. One point which came up as a matter of interest, it was mentioned that the council, Warwickshire County Council, do have a lot of very valuable information of which they were not familiar. So other groups might look into that if they think it might be helpful. Willing to take any questions, please.
Thank you very much, David, and thank you for your continued hard work on behalf of our citizens. Any questions to David? Michael, apologies, you seem to disappear off my screen, which was probably my fault. Was there any update on the End of Life Committee?
Yes, I apologise. Actually, it was my fault. I was just reconnecting for vision and so forth and turned myself off instead. It wasn't fear, however. I attended the committee on the 26th of September, this is re-established now because, in fact, during COVID, it went into hibernation. A variety of subjects pertaining to the overall process of end of life were considered, including the frequency of surveys, because it would seem that the major survey seems to come back at the same time or just after we've had the next survey, and they were going to consider actually the frequency of those, so they had the benefit of the last one before the next one. But that was obviously at a higher level, no doubt, and that they'll be bringing that forward. In relation to governance, it's within the hospital, and it was felt, or seemed to be generally felt, that it would be a good idea if that committee had governance over out of hospital as well. And again, that is something that will be considered, but overall it did seem that that would be a good idea. Hospice at Home webpage and learning were promoted, and what I would say is my general impression is that the committee as a whole would like to emphasise the need for end of life. That's not complaining about what we do at the moment, but everything can do with being improved, and we could do with perhaps more training in the hospital for that purpose. I think my impression is that end of life is not something anybody's very keen on. They're keen on everybody living, and therefore end of life tends to be put at the back of it. Quite probably everybody would agree with that, but it is an important issue, something that I was reasonably well engaged in and know how important it is and how important the effects of the hospital or those dealing with people at the end of life can be. Having said that, I'm only observer and therefore try not to comment, but I am impressed, and I think I should say this, I'm impressed with the committee, who seem to be very interested in improving our project there, and without any doubt whatsoever, they're keen and they're looking for ways to improve.
That's very helpful to get those reflections and observations from you, Michael. Glenn, just quickly, we do invest as a DGH a lot in our palliative care consultants, don't we, compared to many other trusts of our size?
Yeah, I mean, we've got a really excellent team, actually, and I agree with Michael, just some of the innovation that they come up with. And actually, as a result, because palliative care consultants are quite hard to recruit, as a result of having just one or two people who are really, really innovative, we're attracting more people to want to come and work here. So we generally get great interest in jobs because of the culture of the team.
Yeah, no, super. And we're very blessed also with our chaplaincy services, who do a very important job for people at end of life. And I know the feedback, well, we invest a lot in our chaplaincy services and the feedback is always very good. Any questions or perspectives to Michael? As you say, Michael, there's a degree of self-interest for us all in that project, given that we're all going to end up there one day. Moving on to a more positive comment.
I'm trying to stay an observer for as long as possible.
The patient experience group update. We don't have Ruth Cowan with us, and I don't have any notes from Ruth, so we'll have to carry that forward. We've obviously had the update from Sarah Moffat, and we'll try and pick up any points maybe at the next session. So I suggest we move on to the Patient Safety Surveillance Committee update. Sue Warner. Okay, I can't see Sue on my list. We seem to have lost Sue. No, I can't see Sue on my list. So, Sarah, can you see her on your list?
No, I can't, but I'm not sure whether Pat Scott was going to provide this update for Sue, because she did provide the update to the Patient Care Committee.
Okay, great. Pat, are you able to update us on the patient safety surveillance report?
I attended the last patient safety report in Sue's absence, and what I can report is that there were 11 incidents of significant harm, 3 staff incidents. George Elliott isn't reporting COVID incidents. It was felt by the meeting that a conversation was needed with the ICB. Need to keep regulator informed. Last national guidance was in October, and there are variations across the country, and clarity is required. Medication incidents, a potential death was under investigation, re-prescribing of morphine. The family was concerned. The system is being checked. Learning and training to include agency staff. Death of 1 person with a learning disability. Readmission, DVT information being looked at. It doesn't appear to be a trust. There doesn't appear to be a trust information leaflet about this. The NRLS, which is the National Reporting Learning System, is being shelved, and it's being replaced by LFPS, Learning from Patient Safety Events, is taking its place. We're in the top quintile. That's any of 5 equal groups into which a population can be divided according to the distribution of values of a particular variable. Staffing levels, 99%, inpatient that is. 6 SIs were closed. Non-SI tracker, 43, one from 2021, and work is ongoing to get them closed. SI list has been brought right down. Recall of Targocid 200 milligram powder, which was issued by the Medicines and Healthcare, it was products. The regulatory authority had been adhered to and is listed on CAS compliance form. Patient care indicators, 93.4%, slightly under target of 95%. Patient safety incident response framework, monthly update. National programme of work going to impact on ongoing work. Framework was published in August, will mean a different way of looking at work. Response plan is being put together. Quality priorities going to clinical governance in January. LFPS instant reporting, ongoing work to align with national systems. Rollout date was end of March and is now end of September. Looking at systems other than Datex. And the date of next meeting is the 12th of December.
Thank you, Pat. That was very comprehensive. Just before opening it up to questions or perspectives, did you come out feeling assured as to the way that committee was working?
I did. In fact, I did write a little comment, and I said there's a lot of discussion, and I'm sure the general public would be amazed by how much work is put in.
Okay, thank you. Any questions or perspectives to Pat? Okay, thank you, Pat. And I think we're back with you on the patient portal group update. Anything you'd like to brief us on?
Yes, I can just tell you one. Well, unfortunately, I forgot to go to the last meeting, and so I had to ask Devon Bradley if they could provide me with information, because Roger Lloyd was also on holiday. So the update, which I was very grateful to Devon and his team for, was that 58,969 patients are now registered. 86,728 patients have been invited to join, and 68% is the average adoption rate. 33,090 patients decided to go paper-free, and at 82.3%, gynecology has the highest adoption rate as a department. The DNAs, which means did not attend, 8.12% were not registered and 6.23% were registered. During the last 6 months, clinical letters and discharge summaries became available on the portal. A phased rollout commenced at the end of July and completed in September 22. Patients can now sign into the portal using NHS app credentials. Letter types. Approximately, sorry, I can't read my own writing here. Lorenzo discharge summaries, there were 1,500 plus. Lorenzo clinical letters, 500 plus. Emergency department discharge summaries, 3,000 plus. Secretarial clinical letters, 10,000 plus. So what's next? NHS England Wayfinder initiative, linking different organisations' patient portals to the NHS app, providing patients with more information they need about hospital appointments all in one place. Phase 1 is the autumn 2022 and the appointment management in the NHS app, subject to functionality available in individual organisations' patient portal. Phase 2 to be confirmed in 2023, waiting list information, notification and alerts, clinical letters, etc.
Thank you, Pat. And again, just before I open it up, how did you feel at the end of that meeting? You assured us to the way that work is progressing?
I've no idea because I didn't attend. I got the information from Darren Bradley and his team.
Okay, I have to say I'm amazed at how popular the patient portal has proved to be and what the take-up is. I think it's far exceeded our expectations.
Although I was talking to somebody yesterday who lives in Warwickshire and they didn't know anything about it, which did surprise me, so I'm going to follow that up.
No, great, thank you. Callie, is that a legacy hand or is that a new hand?
It's a new hand, Russell. I don't know if it's been discussed in the past, but obviously a lot of information goes on the patient portal. But is that if that system talks to the trust's patient care record, how all that it feeds into the portal? And because it has to be fed at regular intervals and updated and all that, I just wonder if the two systems talk to each other. That's all.
Because it's simplest, Callie. Yes, they do. Otherwise, it wouldn't be relevant. That's one which is quite neat. It is up to date. There's obviously a lag on occasion, but basically, it's quite an effective system. Okay, Pat, thank you for that, again, comprehensive update. Just keeping things moving because we're running a little late now, team. On the Safer Discharge Group update, Jean?
Yes, I can report that this is a very active group. The things that they've been introducing are meant to be over a period of time, but they are actually achieving. They've moved the meetings to 2 monthly, bi-monthly, and unfortunately, although we did meet yesterday, we didn't have a quorum. So some of the things that we're progressing were already in hand, so it didn't actually hurt too much. Just to report that everybody is really thrilled that you had ward to board, or is it the other way, board to ward, and the impact on well-being in the staff, not to mention the learning exercise, and it's been reported that they were dead chuffed to have Glenn come to their ward. They reported. So yes, and it was really nice of Sarah to write an email to me to say how absolutely impressed she was with the fire service work and the joint working between the fire service and the trust. I expect she might take that elsewhere if she gets the chance. But some of the projects that are going on are to do with TTOs and drugs, and Mary is assisting on that with her knowledge of pharmacy. And the technician on Avon Ward plan to improve things has worked really well. And so I believe that it's either got it or it's on its way to Glenn with a business plan for somehow finding some money so that we could have them on more wards, because it really did work and was so successful. But whether you'll be able to find any pharmacists, even if you've got the money, I don't know. In terms of all the different things that are going on around the hospital, I suggested that we really ought to have, I'll tell you what it says. It says, agreed, and we'll ask project team to put something together like a pathway on a page with infographics, because it needs to be seen to join up. It does actually in practice join up, but a lot of people don't know about what's going on, and it's always a surprise when they mention something. There is some concern, well, not concern exactly, but the new doctors start in December, and the last time the last lot started, there were some issues. So they're making sure that a technician attends the new doctors training, and that we try and make sure that we don't have errors, because we did have some errors as a result of their lack of knowledge about how things work. Discharge complaints out of Warwickshire. There is an issue. It's not massive, but it stands out because there's such low complaints in Warwickshire with out of Warwickshire patients discharges. But then that wouldn't be unexpected in a way. But it's still tricky to try and, as you've already mentioned. So what else was there? I think that was the main things, really. I'm just so impressed with the work that they do and how much effort they're making. And looking through, I think, don't want to bore you. Yes, so lots of actions, lots of things, but really, really, really pleased I can provide absolute assurance that it's doing a good job.
That's great. Thank you very much, Jean, and thank you for your hard work. Questions or perspectives to Jean? Okay, thank you, Jean. So I can't see any hands up. So we move on then to Roger, who's kindly produced an update report on the wayfinding strategy group. Roger, what would you like to pull out?
Just a cautionary note, there was reference on the patient portal to NHS wayfinding. That is a completely different type of project to this wayfinding strategy group, which is literally how do you get your way round the various trust buildings? Are you signposted in the right directions? And when you follow it, do you find the relevant service at the end of the trail? Which is not exactly the case at the moment. Group very much aware that if Sophie Gilks gets her estate strategy through, that all the signs are for the bin and we start again. So very much cognizant of that and working thoroughly to make sure that things are done in a timely fashion but not wasted. Next meeting is next week.
Thank you very much, Roger. Any questions to Roger on the wayfinding strategy? I do think it's a disproportionately important piece of work, this, Roger. 1 in 6 adults are functionally illiterate. It always worries me for people who are in that population segment coming to the hospital to be able to find where they're going. And certainly I have on a number of occasions had to help people of a more mature age who are confused as to where they need to go in the hospital. So I do think that the work you're involved in is a very important piece of work for our citizens. Thank you.
It's not helped that some of the signs are not in alphabetical order and have a whacking great long list of them in random order, almost as they were dreamed up by somebody.
Yeah, well, that's why we've set up the strategy group to sort it out, Roger. Thank you.
Thank you.
So just conscious of the time, quickly, Callie.
Yeah, I just wanted to ask Roger if when the group makes recommendations, who in the trust is supposed to change or update notes boards or whatever? Is that the communications team, or the estates? That's all.
It's the estate team.
Okay.
Yeah, it's the estates team. The communication team will be involved on things like typeface and clarity, but it's the estate team that do it. Okay, team, if you could take your hand down, Callie, that would be great. So I think then we're on to the last update from governors on the elective care group. Graham?
Russell, I think Graham's had to leave the meeting, but what he has advised us is that the group hasn't met recently. However, as part of the Council of Governors training earlier today, governors should have received an update on the key development programmes, which should cover that section.
Super, thank you. So we'll look forward to a proper update from Graham. Apologies for the whimpering sound in the background. I've got a young puppy, Rhodesian Ridgeback, who's obviously having a bit of a nightmare on the settee behind me. Shall we move on then to the draft minutes that we've had from the various different subcommittees? Then I'll be able to give you all a comfort break before the confidential Council of Governors meeting. The first is the Patient Care Committee draft minutes from the 12th of September. Jean, is there anything you'd like to add to these?
Not really. We've changed the terms of reference to, and they will be reviewed in January. We've updated them. We're now meeting monthly so that we mirror clinical governance. We get feedback, very dependent on Dr. Spraggett to attend the meeting, and Sue Warner and Ruth Cowan, who you've already reported on. Also, Patients Forum, which is really good because they get a way of putting forward their ideas and what they're doing, attend. And really, I'm really quite pleased at the work that we're doing and the feedback we're getting.
No, great. Thank you, Jean. Any questions to Jean? Roger?
Yes, just a very quick comment arising from our local health centre patient participation group last night. The lead GP was not aware of Badgernet, knew nothing as to what Badgernet was or anything else. So can I suggest that at some relevant point somebody actually briefs primary care as to how relevant it might be or not?
Yeah, Badgernet is a pretty well-known system, isn't it?
That was my thought. I was totally surprised at this particular GP, an experienced GP, and his comments.
Glenn?
Yeah, can lead a horse to water. But I'm pretty sure we actually send information directly from Badgernet to primary care, but I'll check that. But it may be that they don't realise that's where it's coming from.
That's my understanding as well. Badgernet is a system used in maternity, and it's Jane, just seeing your comment in the chat box. Okay, thank you. Any other questions to Jane? Okay, thank you, Jean. So we'll then move on to
just to say, I forgot that a new mum reported, because obviously we've talked about that as well. A new mum reported that her experience was much improved on the last time she was in. So I'll make sure and feed that back to maternity.
Okay, no, that's great. And just to remind governors, the NED safety champion for maternity. So if you've got any issues about it, please feed them towards me. I'm trying to keep things going, but Callie?
Very, very quickly, I just want to ask Jean or Mary, because there was an issue with audits around NICE guidance and performance around NICE guidance. how is that going? Because there were some issues, it says in your report. So how is that going around NICE guidance, audits around NICE guidance?
So,
that's my question.
As this is a public meeting, just for clarity, the only piece of NICE guidance where I think there's been any discussion has been on dermatology services. Is that correct, Len?
Yeah, that's correct. Also, the chief medical officer undertook a review to ensure that there was compliance across a number of specialties. But the dermatology issue was actually an example of going beyond NICE guidance, but a need to ensure that patients were suitably informed and consented on that.
And I think it involved clinical governance, so I didn't refer to.
Yeah. And it was discussed at the last public board as well, Callie, just so you're aware. So we'll move on then to the GPC draft minutes on the 11th of October. Mary, is there anything you particularly like to pull out?
Yes, I'll take the minutes as read, but yes, there are a couple of things I'd like to pull out. Apart from setting the agenda for this meeting, as always, the Council Governor's self-assessment process, which is on the agenda, we agreed that questionnaire. Disappointingly, only 15 out of 26 governors returned it. It is an ongoing annual problem to get the returns, but anyway, we'll talk about that further in the meeting. A questionnaire to survey the effectiveness of the induction programme that we had earlier this year was also agreed, and hope that people will complete that. That's for new governors and existing governors. The vacancy for the Deputy on the Elective Care Group, which Graham sits on, was filled by Andy Petros. Membership engagement was discussed, and suggestions were made how we might increase membership and how governors might get involved in strategy development. It was agreed that the GPC didn't have the time to do justice this membership and engagement agenda, and that we may need to re-establish some kind of committee or other way of dealing with it. And a group of us are working now to look at the possibilities of developing such a group. As was said at our pre-meeting, it was agreed that Richard Coley and Simon Page would meet with governors to discuss F&P and audit issues following on from the executive F&P meeting which they attend. It was also agreed that the 4 newest of the NEDs would meet separately with governors in a get-to-know capacity, and thank you to Sarah, who's actually putting that programme in place at the moment. And we agreed the training programme for the next 3 months, taking us up to January, and we've got a list of topics that we'll look at after that. But happy to take any questions.
That's great, thank you, Mary. Any questions to Mary on the GPC minutes? Can't see any hands raised, so thank you, Mary, for all of your hard work on that. So we'll then move on to the report on resignations and appointments. Sarah?
Russell, I think you've missed an item, and it's the proposed amendments to the GPC terms of reference. Sorry.
Moving on to the report on resignations and appointments. A proposed amendments to the GPC committee terms of reference. Sarah.
Thank you. So the proposed amendments are shown as track changes for ease of reference. Just to highlight that the main changes relate to changing the choracy, because we have had some difficulties with that committee, but it still felt that that would be a good quorum to agree the remit of the committee, and then also alluding to what Mary's just mentioned about the remit around membership, they are shown as points that are under review. So okay. Happy to take any questions and propose that they're approved. Thank you.
No, that's great. Thank you. So any questions on the amendments to the terms of reference? Okay, Sarah, thank you. Are you all happy to approve? Because it does require approval by, I think, the Council of Governors. If you're not happy to approve, please raise a digital hand. Super, thank you. Duly approved. Then we are on to the report on resignation and appointments. Sarah?
Thank you. Happy to take it as read, and just to highlight that we do have an additional vacancy following the recent resignation from Helena Darcy-Cope. So I'm working with the operational chief medical officer and the chief nursing officer to see how we can attract some interest into these two roles before we go out to another election process.
No, thank you, Sarah. I have privately thanked Helena Darcy-Cope for her work over many years as a governor, but I'd like to do it again publicly in this forum. So thank you very much, Helena. Any questions to Sarah on this report? Okay, thank you. So we move on then to the self-assessment of the Council of Governors, which Mary referred to a moment ago. Back with you, Sarah.
Thank you, Russell. I'm happy to take the report as read, but just to highlight that we have included in the cover sheets actions that are being taken to address some of the concerns that have been raised.
No, that's great, very helpful. So
thank you.
I think just before we ask for questions or perspectives, I would strongly endorse what Mary said about the importance of governors filling out this self-assessment report. It's not onerous. And it does help make sure that what we are getting as feedback is statistically significant. Questions and perspectives. Mary?
Just to say that this will be discussed, to the details on the questionnaire will be discussed at the General Purposes Committee in January, so to see what we can pull anything out that we need to be acting upon.
Thank you very much, Mary. And Jean?
It's a shame that more people haven't filled it in, but it may be, which would be even more worrying, that they haven't filled it in because they don't like to make any criticisms, or it may be because they think it's so wonderful, the trust, that they don't need to, when in fact we really do need to get feedback so that we make sure that they feel involved and empowered. So I'm quite, I know it's happened before, but I am quite surprised that it's still happening. And it would help us if they did fill it in, please.
Yeah, no, a point well made. Just before I allow Mary to come back in, John?
Just a small point. I did fill it in, but it apparently arrived too late, so it wasn't included.
I was aware of your input, John, but thank you. And finally, Mary?
It's a very quick point to say that I think some of the new governors found it more difficult because they hadn't had the experience of the committees or the non-execs to give any opinion. But hopefully they replied with saying that they can't comment or whatever, so that at least we got a return of some kind.
Exactly. Thank you, Mary. Okay, look forward to the discussion at GPC. We'll come back to it in terms of the way we operate in due course. Then we're on to the calendar of meetings. Sarah, back with you.
Thank you. Just to highlight 2 amendments to the dates that I've submitted, I did make an error for the February 24 Council of Governors meeting date, and Thursday is actually the 15th of February. So you'll be pleased to know that we won't be expecting you to join us on Valentine's Day for a Council of Governors meeting. And then also the Patient Care Committee had approved their dates before they were submitted to Council of Governors, but in fact, Monday the 10th of April is a bank holiday, so they've decided to step down the meeting in April 23. So subject to those amendments, proposing for approval, please.
Thank you very much, Sarah. If you're not happy to approve this calendar of meetings, could you please raise a digital hand? Okay, super, thank you. So I think then we're on to the Audit Committee annual report. Richard? Okay, I seem to have lost Richard. If you're speaking, I can't hear you.
I think this was the one that was probably meant for me.
Okay. Yeah. Okay. So apologies, Richard. Rosemary.
Okay. Yes. So this is an annual report which basically summarises the work in the last financial year. So it's actually a bit old now, but is completed once the annual financial audit is completed. So it sets out the work during the year, both from an internal, external audit point of view, aspects that the committee specifically looked at, and also gives a summary of attendance at the committee. So I'm happy to take any questions, as I was chair during that period.
Thank you very much, Rosemary. Questions or perspectives to Rosemary on the audit annual report, audit committee annual report? Thank you, Rosemary. And Rosemary, this is the last time you'll be with us as a NED at the Council of Governors. You've been a fantastic servant of the whole of the board, and I'd just like to put on public record again in this forum my enormous thanks, and on behalf of the whole Council of Governors, collective thanks for your hard work. Richard, did you want to add a point?
Just add that congratulations and thanks to Rosemary. The report was a bit late this year because we had problems getting our annual accounts out, but we've taken steps, and Deloitte's are having a meeting, I think it's probably next week, just to make sure that we don't have the slip-ups we had. It was partly COVID related, partly staffing issues, so we're on top of that. So we normally would have been dealt with earlier because the accounts were, what, 2 months late this year.
Yeah, but I believe I'm correct in saying that wasn't our fault. It was Deloitte's.
No, it was their fault.
Okay, thank you, Rosemary. So we move on then to the annual report from the lead governor. Mary.
So yeah, thanks, Russell. Well, given the time and we're behind time, I'm just happy to say take it as read. Hope you've had a chance to read it. Hope it read through, and I'm happy to take any questions.
No, that's great. Thank you, Mary, and thank you for putting it together. Any questions or perspectives to Mary on the lead governor annual report? Thank you, Mary, and that leads us on to the next issue, which is your reappointment as lead governor. And we are a democracy. We're not a dictatorship, but Mary was the only candidate, which I think speaks volumes, actually, Mary, as to the confidence that your colleagues have in the way you conduct your duties. So thank you very much. I know, because of the meetings that I have with you out with these formal meetings, the hard work and seriousness with which you approach the role of lead governor, and on behalf of the whole council, thank you very much and congratulations.
Thank you, Russell.
So I think we're on then to any other business. Is there any other business, colleagues? Would you like to raise a digital hand before we close the public meeting? Pat.
Yes, I just wanted to raise one point about I'd received some posters to distribute in my local area on Boost Your Health Esteem, and I'm very concerned that we are excluding older members of our community because we are only including access online. We do not include any other way of accessing this information, and in my experience, and being one of the older generation, there are a lot of older people who do not have access to and cannot use modern technology. So if this is aimed at the effects of loneliness and isolation, which a lot of older people are affected by, they cannot access the help that's being offered.
Glenn.
As one of that generation also, be very happy to have a look at that, Pat. Could you possibly send me that poster, dare I say, electronically, and I will, I'll just try and track down where it's come from and ensure that it's more inclusive. I completely agree with you. There need to be multiple channels for these things.
Can I just say, Glenn, I actually have emailed Lee Tranter about it.
Okay, you've frozen on my screen, Pat.
Yeah, if you've already contacted Lee, I'll follow up with Lee. That's absolutely fine. I'll do so.
Thank you, Pat. And Mary?
Yes, I've got one issue I wanted to raise. On the ePulse magazine this time, there was a very small, hidden amongst many other things, an item about returning walking aids to the 3 sites they can return to. referring particularly to crutches and walking sticks. And I just felt it should be more publicised. I felt it should be on the website. We should even be putting articles in the local papers as a good news story to actually, because I've got friends and neighbours who've got equipment and didn't know what to do with them until I told them to take them back. They also raised some concerns about returning larger equipment to Millbrook, which I've already raised with Russell. So I'll leave that in Russell's hands. But I thought we ought to be advertising when we are putting in such a system in place.
Yeah, Glenn, just so you I have had a discussion with Mary Powell, so Mary Powell's aware of it. Anything you'd like to add?
No, I was just going to say, as I'm talking to Lee Tranter, I'll talk to Lee, but if Mary's on it, I'll have a conversation with the comms team. But I agree with you, we need to give it more prominence.
Yeah.
Thank you.
That's great, thank you. And any other business or any other questions from governors? Sarah, have we had any questions from members of the public?
No, Russell.
I don't believe we've got any members of the public on the call.
We haven't.
Okay, so what we'll do then is we'll bring this meeting to a close, and if we can, I suggest we have a 5-minute comfort break. I'm not sure whether we've got a separate invitation, which I think we probably have.
Yeah.
So we leave this meeting now, ladies and gentlemen. We go into the confidential meeting, and I'll see you there in 5 minutes. Thank you very much.